Hey everyone, welcome to Your Personal Health. I am Dr. Kim,
And I'm Dr. Burris.
and we are with Coachella Valley Direct Primary Care. And today we wanted to talk about single payer healthcare systems. So thank you for joining us. If you have any questions, please pop them in the comment section, or you can always, after the show, put some questions in and we'll try to answer them. How are you today?
I'm doing good. How about you?
I'm good.
Yeah.
If you didn't catch our last show, we do a COVID show where we talk about the Riverside County numbers specifically, and how things are going. And so the numbers look pretty good. Um, and I think we're optimistically cautious. That's my new line. Fauci has cautiously optimistic. I'm optimistically cautious.
Okay.
I'm copywriting that.
Okay. I'm hopeful. I'm watchful waiting. Yeah. So, I'd like to, well, why don't you ask me?
So, Dr. Burris, what is single payer system? What is that? I mean, do we have that here? What countries have that, and why is that an attractive model?
Okay. So there's lots of discussion for years about different types of health systems, and there's been some, probably like jargon or lingo that's popped up. And one of those is the term single payer healthcare, or sometimes you'll hear it called universal healthcare. And really what that means is that there's one entity paying the bills. So that's your single payer. And usually in a universal or single payer system, that's the government. And so usually when you hear this term, single payer healthcare, some people who don't like it will call it socialized medicine. Other people who do like it will call it universal healthcare. So it's one of those value neutral terms that we've used to try to talk about this in a situation that becomes kind of politically fraught very quickly, because there's a lot of assumptions about what that type of healthcare is like and what the pros and cons of it might be. So, the answer to your question is there are a lot of countries in the world that have a form of this. Um, and there are a few countries in the world where that's the only type of healthcare available. But honestly, there aren't a lot of countries that are like that. Most countries have some hybrid where they have a government funded healthcare system with a private healthcare system overlying it. And I suspect that if the United States moved towards a system like this, we'd probably end up with something more like that overlaid system where you had sort of a single payer government funded healthcare system that was available to everyone, and then options for people to purchase a either more personalized or faster care. So when you hear, single payer, universal, socialized, what are some of the negative things that pop into your mind about that?
I think the first thing that everyone worries about is, well, then it's good and dandy for the common things, but if we hear all the horror stories of, I need to get my knee replaced, or I need to get open heart surgery and it's not quite emergent, and oh, I need to do this or that. You can wait a year or two in some systems because it's not something that's critical and urgent. It's something that can wait, and so you do wait, and so people will go other places to get those done.
Or people with means.
Right.
Yeah. So it ends up still having an element where it's not completely fair. People who have money are still getting higher or better health care because of their ability to access outside of that government system. Um,
Well, some of those systems, if the doctors don't play in it, then they can't obtain payments from that system. So even if they wanted to, you couldn't just walk into an orthopedic surgeon's office and say, "Hey, can you do my surgery for X
right,
amount of
right,
dollars?" Because then the government says, "Well, you can't do that."
right. You can't book the operating suite.
Right.
Yeah.
Right. So you either have to go out of the system and take cash, or
Another con that I've heard from people who are working in that system is frustration with some of the limitations that are put on them. So much like when we were working in an HMO system, you had to follow the way they said, and it was designed to be the cheapest way possible, not necessarily what your individual patient needed. And I think as a doctor, that's probably one of my fears about a system or dealing with a system like that is just getting your hands tied and not being able to necessarily get what your patient needs. Um, the other thing, in Canada, they actually restrict movement of doctors across um, provinces, and they're calculating numbers of doctors in each place. And so they're really trying to make sure that they have within the healthcare system doctors where the people are, and enough doctors to meet the needs of the medical needs of the country. So there are some pros and cons from a clinical perspective if we take you know the funding out of it. So we've kind of hit some of the cons about a system like this. um, are there pros about a system like this?
yeah, I think the pros are that you want your society to be healthy, and health is something that if you ignore, it will go bad, just like a car. And so having a way where at least we know the things that are going to be a good bang for the buck of society, having those, being able to, anyone can have done reasonably in a reasonable time, I think is something that is good for society. Or we're going to be paying for the sick from the people who aren't sick. And so I think that's one of the good things. The other thing is it, makes it more transparent than if you have, 20 different plans and you have no clue as to, well, what is this costing? And they're always constantly changing.
Yeah, I would say in so many ways it's simpler for everyone to use, because you don't have to worry, is this person in my network or not in my network? If I'm on vacation, and I need stitches, I can just go into the clinic or the ER. Or if I break a bone, I don't have to worry about, like, I'm going to get this astronomical out of network charge or something. um Also, it tends, it's not necessarily free, but it tends to be much lower cost. So the reality of our current healthcare system is it's really great for the people who it's really great for, and really not so great for a lot of people. And we ourselves know multiple people who just either lost insurance or lost a job that was providing insurance, or something happened where they can no longer get the medication that they need in order to function. And so because of that, they can't work. And now they're looking to apply for disability to try to get on, Medicaid, so that they can get that medicine back, so they can go back to work. And you know, I've seen people who just needed a knee replacement in order to be able to do their manual labor job, but because they didn't have insurance, they could not get that knee replacement and ended up on disability for like 40 years. I mean, that's the cost to society and to that person and to that person's family is unnecessary for that one surgery that could have changed the whole trajectory of that person's life and made them, instead of taking from the pot, actually giving back into the economy. So to me, I'm like, it's kind of a no-brainer that our overall health as a country and our overall health as an economy is going to be better if people aren't being sidelined and bankrupted by health conditions that are fixable. To me, I'm like, this is, if we're going to do some investment in our country, we should be looking at that. Also, the way we're doing healthcare in the United States right now is very expensive, and we're not getting a lot of bang for our buck. So if we are only paying for life-threatening emergencies, like if you have no insurance and you get, say you get pneumonia, you go to the ER, but you're not sick enough to be admitted, you just get a bill for like $5,000 and you get sent home and you're on collections and your wages are being garnished. If you are sick enough to be like on death's doorstep and need to be admitted to the ICU, you actually now qualify for emergency Medi-Cal and your costs are covered. So the government will pick up that $500,000 bill. But if they had just paid for that person to be seen in a clinic for $100 2 weeks earlier, could have saved us that 500 grand. So we're recognizing that, at some point hospitals need to be paid, and ethically we don't like turning people away to die on the street. So we'll step in and take care of them right before they die at the most expensive moment, rather than taking it back when it's cheap and taking care of people before they get that sick.
Right. And so, I don't want to go down the rabbit hole, but I think you mentioned something that for me, it's a conundrum. It bothers me that there are these large groups, whether they're hospitals, insurance, pharmacy, their sole job is to make money. And so, what is enough money for health? What is enough money for me to charge for X drug or Y procedure? If I can charge $10,000 versus 20,000, should I be able to do that? If I can charge 100,000, should I be able to do that? If I can charge 500,000, should I be able to do that? And those, I think, are the tough questions that we need to recognize, that we don't have unlimited resources. And so, like you said, there are certain things that are probably good for society, not that you wouldn't value them, they're just good. And then there are things that we value that are just not good for bang for their buck. If we spend all our resources there, it's not going to amount to much of an impact.
Right. I think, coming back to how much should you be able to charge, everyone always says, well, the drug companies need to recoup their investment. And that is true. However, we didn't always have our medications all being developed by drug companies. We used to actually do that basic lab research more in universities and in government institutions like the NIH. So we used to be doing more of our sort of like our initial research at those like alternatively funded areas. So the cost of developing the drugs was much lower. And so if we can bring drugs to market and get them there in a way where the companies that are taking risks and putting the money in are still getting profits and they're still profitable, but that we haven't put all of our eggs in those baskets, because now we're like basically at their mercy. If they say, we're not going to develop any more antibiotics for staff, and we want to focus over here. And yet, as a medical community, we're saying, we're out of some of these meds, like none of them are working. We've got all these resistant bacteria. We need new antibiotics. We've been saying this for 15 years, and we have very, very few new antibiotics. And we're looking at all these infections that we have nothing to treat them with. And part of that is because it's not lucrative to develop those drugs yet. When people are rampantly dying of their resistant organisms, of their basic UTIs, then all of a sudden we may get some research here, but it's going to be another 5 years before we get that drug to market. A lot of people will die in the meantime. So I think thoughtfulness about where our funding is going for medical research, for healthcare, where's it coming from, who's paying for it, and how does that actually affect the individual patient trying to get what they need.
So we've talked about single payer system, and then therefore, if there's a single payer system, there must be a multi-payer system. Where does direct primary care kind of fit in that, and why did we choose that model?
So basically, direct primary care takes all of it and like bundles it up and throws it out the window. Hey. And that's, basically we spent 20 years trying to work within all these systems. And I still do work within these systems. It's not like we can completely escape. But honestly, we recognize that, we can advocate and try to improve whatever system we're handed. But in reality, it's never going to be fast enough or good enough to meet our individual patients' needs. And it certainly wasn't working for our patients. So we went with direct primary care. So that is a completely different model where we don't work with single payer, we don't work with multi-payer, we work with our patients. And so we have this direct relationship with the patient and are outside of all of the insurance systems.
Yeah, I think doctors smarter than us realized that the system that was currently occurring wasn't going to be able to sustain itself. And so they came up with what is termed direct primary care today, but it's exactly what you said. It's stepping outside the system and saying, why do primary care doctors need to be involved in the insurance system, right? So insurance inherently is for things that you want to hedge your risk upon, but they don't absolutely occur, right? So we have our house insured for fire, for destruction, for things, but we're not expecting that to occur. We hope it never occurs. And that's why we can afford our home insurance. But our home insurance doesn't insure for light bulbs breaking and toilet clogs and the air conditioning going out. There are home maintenance programs, but that's different, right? So the equivalent in healthcare is there are certain things that should be insured for because they don't happen as often to everyone. I mean, knock on wood, I've never had my appendix taken out. I've never had a tonsillectomy. These are things that I've never had done. But there are absolutely things we know that'll occur, right? We need certain blood draws depending on your family history. Women need certain things. Men need certain things as we get older. Those are the things that can't be insured because we know they're going to happen. So to insure that raises the insurance premiums. So direct primary care says, no, as primary care doctors, we can control costs better, do the things that we know that are going to happen on a day in, day out basis, and leave insurance for the things that we hope never happen. But if they do, they won't bankrupt you.
So do people then use their insurance when they come here? How does that work for them?
Right, absolutely. We have people with insurance and without insurance. And the people with insurance absolutely find it still affordable because what we do is we use your insurance when it's good for you. We're very transparent. And from age 0 to 45, it's $99 a month. And from 46 and above, it's $145 a month. And that's all you pay. There's no co-pays. There's no anything when you come. You can come 100 times. You can call us. You can text us. What we do use your insurance for is if we need to go outside our clinic and say you need some kind of test or a specialist, we will leverage your insurance and get you what you need. We'll also tell you, hey, it's this X amount of dollars if you want to pay cash. And that way people have choices as to, okay, do I want to pay $40 for my x-ray by cash or use my insurance? And some people, the answer is going to be absolutely use your insurance because it's free. And the other is sometimes it's going to be no, $40 is going to be cheaper. So, but we give people those choices. And so it's not whether we do or don't take insurance. We will use your insurance if you have it. And if you don't, we will still try to find the best value for you.
So just to clarify, we don't use your insurance for us.
Right.
We use it for when people need to go outside of our practice for specialty care, etc. So my other question was, well, what if people aren't even like citizens? What if they're from Canada? Is this an option for them?
Sure, whether you're from Canada or from Mexico or from a different state. Part of the problem is if you're here long enough, you might run into some medical needs. And you're a doctor, if you have one in those places, cannot practice in the state of California unless they have a state of California license. So we don't require anyone to have any prerequisite other than being alive to be a member of our clinic. So if you're from Canada or Mexico and you need a doctor or a primary care doctor, or you want access to the system, because the other thing is, if you don't have a doctor here, your only options are urgent care and ER. So if you want to open up other options, then something like our practice can absolutely help you, because we don't require you to be part of an insurance panel. We don't require you to have this or that. You don't have to have a US passport. You're here and we want to take care of you.
So one thing that we've heard from people who come from countries who have single payer is that they are often frustrated by the length of time that they have to wait to get into an appointment. And we even hear that from people in our own system, that's the primary frustration is if you have a problem that needs to be taken care of right away, you're usually sent to an urgent care or the ER, and your doctor usually can't see you for a while. What is the availability here for people?
Oh, 30 days. No, I'm kidding. It's same day, next day. It's really what's best for the patient, right? We have business stated hours because we have to, but we stay early, or we'll come early, we'll stay late, we'll come on the weekend, because the system hasn't overloaded everyone, right? We're not overburdened, the patients aren't frustrated. So whatever really makes sense for patients, we'll do. An example is that we had someone call us, and their daughter had fallen and hit her head on the sidewalk and had a cut on her eye right here. And they had called the urgent care near them, and they said it'd be 3.5 hours. So they called, and this was at 5:15 in the afternoon, and they said, hey, what do we do? I said, absolutely, come over here. And so we made sure she was okay, and we glued up her eye, and she was out in 15 minutes. And so
Well, you didn't glue her eye shut. You glued up the cut.
No, you have the other eye, so one eye's no. So I glued the cut closed. Yes, that's correct.
Thank you.
She's not walking around with an eye patch. So, but so that was something that they were able to do. It was very easy. She wasn't scared, the daughter, because there weren't 1,000 people here. It was a pleasant experience, and so those are the things that and that was all covered by the membership. And so these are the things that we think that old time doctors used to do, and things that we think that are enjoyable for everybody.
Yeah, I actually really like taking care of patients this way. I feel like I'm doing what I went into medicine to do. So I'm happier providing care this way, and I feel like it has a better outcome for our patients because those problems are getting taken care of right away when they're little. And you don't end up down the road ending up having to go into the hospital for something that could have been treated.
Right. So now, after someone has listened to the show and they're obviously saying, I want to join, how do they do that? What's the process?
You can call or text us at 760-642-5549, or you can go on to our website at Coachella Valley DPC, that stands for Direct Primary Care.com, and our information and contact is there. You can text us. We can set up a time for like a video chat, a nice free 10-minute phone call. People can come into the office and we can arrange a time for you just to ask some questions and check it out. Again, it's free to do that. And then you can make your decision about whether or not this is something that you think would be beneficial.
Yep. And then you join, and then we start being your doctors.
It's pretty simple.
Yep. I want to join.
You are already a member.
Thank you.
Founding.
Wow. I feel special.
You should. You've got great healthcare.
I know my doctor. Well, we want to thank everyone for joining us on the show today, and stay safe out there. Hang tight. We're almost out of COVID, but we're not quite out of the woods yet. Definitely go get whatever vaccine you can get. April 15th is no restrictions. And
16 and up.
So yeah, sorry, 16 and up.
That's about it.
Yep. Thank you, everyone. Have a great day.